Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, a close look at Healthy NYC. Dr. Ashwin Vasan, the Health Commissioner of New York City, talks to Dr. Josh Sharfstein about a new effort to extend life expectancy that brings together efforts to help the whole population with initiatives focused on those most at risk. Let's listen.
Commissioner Ashwin Vasan, thank you so much for joining me on Public Health on Call to talk about New York City's campaign for healthier, longer lives. Now, why is the Health Commissioner of New York, are you focused now on life expectancy?
Thanks, Josh, for having me. It's great to be here with you and your audience. You're talking about Healthy NYC, which is our campaign for healthier, longer lives that we launched in early November. And it's a response to a couple of things. Number one, as I came into this job around Omicron, and let's say we were through the worst of the pandemic, the one lesson of the pandemic is that in a moment of crisis, we were able to focus and we were able to align our energies. You can debate whether those were well aligned or not well aligned, but at least we knew what we were fighting. And like you, for someone who spent his entire career working in different aspects of public health, health can sometimes seem extraordinarily broad and extraordinarily diffuse. But when we can marshal our energy towards unifying goals, we can do great things. I came up through the world of HIV and HIV treatment, and I saw us do great things at the turn of the century globally on expanding access to care. So one, I was asking myself the question, what's going to be our unifying set of goals? What are we going to focus on in the post-COVID emergency era? Number two is that we started to unpack the life expectancy data, our vital registry data, and saw an extraordinarily alarming, not entirely surprising, but very alarming trend, which is that in 2020, New York City lost 4.6 years of life expectancy, and Black New Yorkers lost 5.5, and Latino New Yorkers lost 6 years of life expectancy. And we know some of that's not surprising because New York experienced nearly 50% of its total COVID deaths in the first 3 months. But on the other hand, my team and I looked at the data and said, well, it's not inevitable that we're just going to get right back on track. It's not inevitable without organized, intentional action that we get back towards healthier, longer lives. And the last thing is something's wrong in the richest city, in the richest country in the world, when we don't have a civic expectation that the product of our choices as a democracy and as a society is going to lead us to live longer and healthier lives. And so all of that taken together felt like a moment to crystallize action, a moment to galvanize our public health system, and a moment to set our city out on a new trajectory.
Got it. So you have this momentum, in a sense, from COVID response that you're really trying to turn to a fundamental question of life or death in New York.
I think that's right. The product of our work at the end of the day has to have some measure to it, and not just some measure that we look at process measures or even individual disease metrics, but what's the overall sum of our efforts? And can that sum be tracked over time? And can that sum be compared between jurisdictions or parts of the country, parts of the world, frankly? And so we landed on life expectancy, understanding its limitations and its gaps as the best summary measure of health that we could land on to organize action.
So you're sitting around with your team, your sleeves are rolled up, you're looking at the various communities of New York. How do you tackle life expectancy?
The first principle we landed on was that we wanted this to be quantitative as much as possible. So we wanted to start and end with the data that alarmed us. which is our vital registry and our mortality data. So when we saw the overall life expectancy trends in the city, our first question was, what are the drivers? What are the leading causes of death? And what are the drivers for which we feel like there are clear strategies to make them modifiable, to bend the curve? So we started with those data. We looked at our leading causes of death. We modeled past performance as well as future outcomes to say, what could be reasonable expectations for where we might get to by 2030? We set out 2030 as a goal, as a benchmark. And then number two, what are the different strategies underneath it? What are the high-level buckets of strategies that we think will help us get there? And in doing that across the top 7 or 8 leading causes of death in New York City, we identified another opportunity, which felt to us like an evolution of our work in public health here in New York and more broadly. One is that we've focused a lot on reducing overall population risk in this city, whether it's tobacco control or changing our dietary system, our nutrition system by eliminating toxins. Those tend to be citywide, area-wide, universal policies that tend to flatten communities, but they affect everyone, and hopefully they affect everyone positively in some fashion. Over the last decade in New York City, we've found that place-based work is extraordinarily helpful and extraordinarily needed to drive equity. So going to where the disparities are the greatest, where we're seeing the disproportionate burden of disease, and actually leaning into community partnerships, leaning into place-based work, leaning into partnerships between healthcare, housing, social services to address both the root causes as well as the downstream services needed to modify health. And lastly, excess death. Where are we seeing the most vulnerable groups disproportionately impacted across all of these drivers? Well, you look at older New Yorkers, older people. You're looking at people who are members of the disabled community. You're looking at people with underlying immunosuppression and chronic illness. And you're looking at people who live in congregate settings like jails and prisons and shelters, people who are unhoused as well. And so we thought that there's an opportunity here to merge these traditions in public health, to not necessarily say that they're in competition with one another, but rather there's a big tent here. And that we can both address overall risk, center equity, but very newly take on this issue of a priori risk and vulnerability as a part of our population health planning.
Let's talk about an example of how you can take that strategy and make it concrete. Pick maybe one of the focus areas for Healthy NYC, and let's talk that through.
Yeah, so the leading cause of death in New York City is cardiovascular disease. Has been for a long time. Number 4 leading cause of death is diabetes. We fairly modestly have set out a goal to reduce diabetes and cardiovascular disease deaths by 5% by 2030. As you can imagine, there's a number of ways to get there, but it starts with what are the upstream risks and the upstream drivers of the development of those chronic cardiometabolic diseases. Exposure to toxins in our food supply, things like added sugar, added salt. Just days after we launched Healthy NYC, we passed something called the Sweet Truth Act here in New York City, which will force chain restaurants to publish the levels of added sugar they have in their food supply. So those are examples of that overall, very classic, something that New York City is very known for, population-wide risk factor reduction. But we leave a lot of people behind in that process. And there's a lot of people with illness already who need their life extended, life improved, and their outcomes modified. So that's where we lean heavily on place-based work. When we look at place-based work, what does it correlate with most? Premature mortality. The populations that are dying below age 65 in New York City disproportionately are Black and Latino New Yorkers. And the communities where Black and Latino New Yorkers live in concentrated ways are those with the worst health outcomes. So centering our work using strategies like community health workers, using strategies like connecting to low-cost insurance and access to care, patient navigation, as well as these upstream drivers, have a real effect on equity and a real effect on bending that curve of premature mortality. And then lastly, what are we doing amongst the already vulnerable, amongst people with multiple chronic conditions? What are we doing amongst older New Yorkers who live with chronic disease? And what are we doing to increase their access to care? What are we doing to ensure they're getting their necessary screenings, that they're getting evidence-based care for hypertension, for hyperlipidemia, and so forth? And what are we doing in our jail and prison population and in our shelter population, where we know that rates of smoking are higher, rates of chronic disease? The number one leading cause of death for the formerly incarcerated after they leave is, as you might expect, cardiac arrest and heart attack. And this is happening in a population that's well below 65, because most people are well below 65 as they're cycling in and out of the justice system. And so why is that? Well, it's a cumulative effect of nutrition, access to care, and other risk factors like tobacco and alcohol. So when we take those approaches together, those are just examples of how the city then puts together a strategy that it can both own and operate on its own, but also direct other parts of the city, other agencies, other partners, private sector, nonprofit sector.
And all the while tracking very carefully what's happening.
Correct. Much as we laid out quantitative goals, none of it works unless underneath those goals we've got KPIs and metrics that we can track over time and report back out to the public on our progress.
So I know we don't have time to go through all of them, but besides cardiovascular disease and diabetes, what is in your focus list of topics for extending the life expectancy of New York?
Oh, so many. Cardiovascular disease and diabetes, overdoses, which is obviously proceeding in a really dangerous direction for our country and for our city, suicides, violence, interpersonal violence, screenable cancer deaths. And we've also included Black maternal mortality because it's the most pernicious and most extreme racial inequity that we see in our data. And we think it's modifiable with action. From a volume perspective, it may not be in the top 8 causes of death in terms of its disproportionate burden on equity in the Black community. It's really important to lift this up in a population health agenda for the city.
Got it. Now, it sounds like you have mapped out a lot of specifics in this strategy. When you take a step back and you look at the challenge of life expectancy, are there any themes that jump out at you?
Well, we have focused on these very measurable causes of death. These are the causes of death that are written on every death certificate in our city. We'd be remiss if we didn't talk about the cross-cutting factors that impact things like access to healthcare, things like climate change and the quality of the air we breathe, the water we drink, and the extreme weather, which really takes hundreds of New Yorkers every year from us too soon. And of course, mental health, something that I've focused a lot of my time and effort on. The impacts of mental health, not only directly on things like overdose, suicide, and in some cases violence, also have major indirect impacts in terms of the impact of mental health on diet and nutrition and movement and chronic disease outcomes. For example, mental health and maternal mental health is one of the top 3 leading causes of Black maternal mortality, of maternal mortality overall, but especially in the Black community. You know, when we look at these cross-cutting variables, the work that we're doing to address things like mental health, whether it's focusing upstream on youth mental health, focusing on the needs of people with serious mental illness, or drilling down on overdose, these most vulnerable communities, they all ladder up and link up to these mortality data that are driving this population health agenda for the city. So Healthy NYC is not meant to supplant or replace any of our disease-specific or population-specific initiatives. If anything, it's just an umbrella. It's an umbrella so that we can say to our city, we're actually pointed in this bigger direction, and all of this work ladders up into something much greater than our ability to achieve on our own.
You give people, whether they're working for the health department or working in the healthcare system or in other parts of community organizations, you give them an opportunity to see how their work contributes to an overall goal that people share.
Absolutely. And that's been one of the most exciting parts of the launch of Healthy NYC and the development of Healthy NYC is to see how many of our fellow New York City agencies, all of our health systems, our payers and our managed care system as well as community-based organizations, how many of them see themselves in this effort and can see themselves in this effort? We cannot achieve this on our own. The health department and the public health system in many ways is simply using its expertise and its data to serve as the city's health strategist, to really bring people together around a common agenda. But we will need everyone rowing in the same direction. The other piece I just want to highlight about why Healthy NYC is really, I think, hopefully useful in the long term is that we recognized early on that this is long work. And so from the beginning, we've worked with City Council to pass a complementary Healthy NYC law, which says that every 5 years, we need to come back to the table as a matter of law and re-up these goals, report on progress, and establish a new population health agenda for the city of New York that focuses on life expectancy. And that acknowledges that this must outlive any mayor, any administration, or any health commissioner or other leadership in order for it to be successful. This cannot just be the pet project of one group of people. This needs to be the long work of improving health. And so very grateful that we had legislative support to do this. So that should be getting passed in early 2024, was introduced at the same time that the campaign was launched.
Great. Well, congratulations on getting going. It's an incredibly important accomplishment, and New York has for many years shown quite a lot of leadership in public health, and that certainly is continuing now. Dr. Vasan, thank you so much for telling us all about it on Public Health On Call.
Thank you so much, Josh, and I really appreciate what you're doing here.
Public Health On Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.